Hello everybody. Today we are going to discuss about cryptococcal meningitis. So we had this 36-year-old female patient known case of hypertension, hyperparathyroidism, underwent renal transplant in 2022 in view of lupus nephritis. So the currently patient was on the following medicine. She was on tablet Biomus, tablet Biomif, tablet Visalon, tablet Silacar, tablet Renopress, and tablet Febri. So she presented with the chief complaint of confusion since 2 days, vomiting since 1 week, on and off, or decreased oral intake, and the irrelevant talk. Recently, she was admitted for the severe gastroenteritis. So she underwent lab investigation, which revealed severe hyponatremia with sodium level of 113. For hyponatremia, she was treated with 3% hypotonic normal saline. There was also new onset proteinuria with acute kidney injury on chronic kidney disease with transplant kidney. So for this new onset proteinuria, biopsy was done, which showed suspicion of antibody mediated reaction. This hyponatremia was due to secondary to so when that biopsy report came, we thought this hyponatremia is due to secondary to this chronic kidney disease. So since the patient was also complaining of severe headache and diplopia. So in view of severe headache, the MRI brain was done, which showed chronic venous sinus thrombosis. So she also underwent fundus examination because the headache was continuous throbbing. So that fundus examination revealed disc edema with the elevation of the disc with retina attached, and it was normal. So both eye papilledema, which was suggestive of raised intracranial pressure. So CSF was advised for same, but relatives refused for that. Finally, this patient was shifted in ICU in view of breathing difficulty. The chest X-ray was done, which was suggestive of pulmonary edema. So in view of fluid overload, this patient underwent dialysis. On 12th of April, the patient was unresponsive, which was lasted for 2 to 3 minutes. Then she regained consciousness. So after this, she had recurrent episode of transient unresponsiveness, which was so we were suspecting seizure at this point. So we intubated her in view of low GCS. And to know the cause, we performed lumbar puncture. So she underwent lumbar puncture, which showed RBC of 18, WBC of 272, neutrophils 4, lymphocyte 72, monocyte 24, protein of 44, and glucose 29. We also did biofire, which was positive for cryptococcus, and the blood culture was suggestive of Klebsiella pneumoniae, carbapenem resistant enterococcus. So EEG was done, which showed slowing. MRI brain was done, which was suggestive of cerebral edema. Patient's pupil, after this patient pupil become fixed and dilated. Brainstem reflexes were absent. Repeat EEG done, which showed the isoelectrical line. So, in view of Cryptococcus meningitis, we have started her on amphotericin B, 300 mg IV OD, flucytosine 375 mg IV QID, injection acyclovir 500 mg IV OD, injection zavicefta 2.5 mg TDS, injection astronam 2 gram IV TDS, tablet biomif 360 mg, 2 tablets twice in a day. Then she was also started on the anti-epileptic steroids, tablet Corbis and Renopress for hypertension. So since this patient was finally diagnosed with cryptococcal meningitis, we'll discuss how to deal with this cryptococcus meningitis. So cryptococcuses accounts for substantial morbidity and mortality globally. In 2022, WHO listed Cryptococcus neoformans as a top fungal priority pathogen. Cryptococcuses often involve CNS or lung, but disseminated disease can affect any organ. Mortality from cryptococcal meningoencephalitis is quite high, ranging from 24 to 47% at 10 weeks. So, for cryptococcal strain is further divided into two species, that is cryptococcal neoformans and cryptococcal gat. Now about pathogenesis, cryptococcal infection is acquired in the form of aerosolized particles. The two leading candidate forms are yeast cell and basidiospores. Inhalation of the cryptococcal cells and the spores can lead to state of latency in which viable organisms are harbored for prolonged period and that can lead to into granuloma formation. So cryptococcosis is usually presents as chronic meningoencephalitis. The mechanism by which fungus undergoes extrapulmonary dissemination and enters central nervous system remains poorly understood. So the cryptococcal capsule is also antiphagocytic, and the capsular polysaccharide has been associated with deleterious effect on the immune distribution. So cryptococcal infection can elicit little or no tissue inflammatory response. So clinical manifestations are so it manifests as meningitis, pneumonia, skin, and soft tissue infection. Let's talk about meningitis. So CNS involvement usually present as signs and symptoms of chronic meningitis like headache, fever, lethargy, sensory deficit, memory deficit, cranial nerve paralysis, vision deficit, and meningitis. Classical characteristic of meningeal irritation such as meningismus may be absent in cryptococcal meningitis. Indolent cases can present as subacute dementia. Meningeal cryptococcus can lead to sudden catastrophic vision loss. Now, the next manifestation is pulmonary cryptococcosis. Pulmonary cryptococcosis usually present as cough, increased sputum production, and chest pain. Patient infected with Cryptococcus gattii can present with granulomatous pulmonary masses known as cryptococcomas. Fever develops in the minority of the cases. Many cases detected incidentally after abnormal chest radiograph obtained for other diagnostic purpose. Pulmonary cryptococcosis can be associated with antecedent diseases such as malignancy, diabetes, and tuberculosis. So skin lesions are common in patients with disseminated cryptococcosis and can be highly variable, including papules, plaque, purpura, vesicles, tumor-like lesion, and rashes. In patients with AIDS and solid organ transplant recipient, the lesions of cutaneous cryptococcosis often resembles those of molluscum contagiosum. So this is the skin lesion, skin manifestation of cryptococcal meningitis. Now about diagnosis. A diagnosis of cryptococcosis requires the demonstration of yeast cell and cryptococcal antigen in normally sterile tissue. Visualization of the capsule of fungal cells in CSF mixed with India ink remains a useful rapid diagnostic technique. The CSF India ink examination may yield negative results in patients with low fungal burden. Cultures of CSF and blood that are positive for cryptococcal cells are diagnostic for cryptococcosis. In cryptococcal meningitis, CSF examination usually reveal evidence of chronic meningitis with mononuclear cell pleocytosis and increased protein level. A particular useful test is cryptococcal antigen detection in CSF and blood. The assay is based on the serological detection of cryptococcal polysaccharide and is both sensitive and specific. Major advance in the recent years has been the introduction of rapid point of care cryptococcal antigen that provides results in minutes. So this positive cryptococcal antigen test provides strong presumptive evidence for cryptococcosis. Because the result is often negative in pulmonary cryptococcosis, this test is not very useful in diagnosis of pulmonary disease and is of limited usefulness in monitoring response of the disease. Now we'll see what are the high-risk patients. So high-risk population includes the patient who are diagnosed with HIV, then solid organ transplant recipient, individual with the other immunosuppressive condition, and those who receive the immunosuppressed drug. Those who survive cryptococcosis report substantial mortality ranging from 10 to 17%, totally based on disease nature. Now the recommendation for population at high risk, clinical presentation and outcome. So cryptococcosis should be considered in any patient presenting with compatible symptom or microbiology, regardless of the immune status. So among patients without known predisposition to cryptococcosis, exclusion of underlying immunodeficiency is recommended. So yeast causing cryptococcosis and diagnostic method. Cryptococcus neoformans species complex is predominant causative agent of cryptococcal in people living with HIV. Cryptococcus neoformans has a strong predilection for CNS disease. Cryptococcus gattis species complex are more commonly causing disease in people who appear immunocompetent. So Gatti is more commonly associated with pulmonary disease and the large cryptococcus. Recommendation for yeast causing cryptococcal and diagnostic method. All patients with suspected and confirmed cryptococcal require clinical assessment for CNS, pulmonary, and other body site involved. So the investigations for disseminated disease should include lumbar puncture with measurement of CSF opening pressure, glucose, protein, cell count, microscopy, culture, and quantification of CSF cryptococcal antigen. Now, the quantification of CSF cryptococcal antigen and cultures of the blood sputum and other affected sites. Brain imaging and in the form of MRI and chest imaging in the form of CT is also required. Now about HIV infected patient. Adult living with HIV who are on antiretroviral therapy, who are naive or after period of ART discontinuation with CD4 cell count of less than 200, they must have lateral flow assay of the blood cryptococcal antigen for screening of cryptococcus. If it is positive, then the cryptococcal antigen titer should be measured. All patients with cryptococcal antigenemia should be carefully assessed and investigated for cryptococcal and treated as appropriate. Now we'll see how should we treat this HIV-associated cryptococcal meningitis. So the total treatment is divided into induction phase, consolidation phase, and maintenance phase. This induction phase lasted for the 2 weeks, consolidation phase lasted for 8 weeks, and maintenance phase lasted for 12 months. So what we are starting in induction phase? In induction phase, we'll start with liposomal amphotericin B, that is 3 to 4 mg per kg daily plus flucytosine 25 mg per kg 4 times a day, or single dose liposomal amphotericin B, that is 10 mg per kg, and 14 days of flucytosine, that is 25 mg per kg 4 times a day, and fluconazole 1200 mg daily. Then next comes consolidation phase, which lasts for 8 weeks, in which we are starting fluconazole, that is 400 to 800 mg daily. Then for maintenance phase, which lasts for 12 months, we can start with fluconazole 200 mg daily. If liposomal amphotericin B is not available, then we can start with amphotericin B lipid complex. But this component is not available in India, so we won't discuss much. So if liposomal amphotericin is not available, we can go with plain amphotericin B, and the dose of it is 0.7 to 1 mg per kg daily with flucytosine 25 mg per kg to 4 times a day, or amphotericin B 1 mg per kg daily and flucytosine 25 mg per kg 4 times a day for 1 week, followed by fluconazole 1200 mg daily for 1. If flucytosine is not available, then we can start combination of amphotericin B plus fluconazole. Like liposomal amphotericin B 3 to 4 mg per kg daily plus fluconazole 800 to 1200 mg daily, or we can start amphotericin B lipid complex 5 mg per kg daily with fluconazole 800 to 1200 mg daily, or amphotericin B dextrin, that is in the dose of 0.7 to 1 mg per kg daily plus fluconazole 800 to 1200 mg daily. So if amphotericin B based therapies are not available, then we can start with the flucytosine 25 mg per kg 4 times a day, or fluconazole 800 to 1200 mg daily. If only fluconazole is available, then we can start fluconazole 800 to 1200 mg daily. Other treatment are voriconazole, posaconazole, isoconazole, itraconazole, but these are not much practiced drugs, so we won't discuss it in detail. Now let's talk about asymptomatic cryptococcal antigen. In people who are living with HIV and who have asymptomatic cryptococcal antigenemia but without clinical cryptococcus, after thorough investigation, uh, even if the patient is asymptomatic, we need to start the fluconazole 1200 mg daily for 2 weeks, followed by fluconazole of 800 mg daily for 8 weeks, and then 200 mg daily for 6 weeks. In clinical setting where cryptococcal antigen lateral flow is not available, then universal prophylaxis with fluconazole 100 mg daily in people living with high endemic area with CD4 count of less than 200 is recommended. Now the cryptococcal meningitis in single organ transplant, solid organ transplant recipient. So the cryptococcosis is the third most common invasive fungal infection in solid organ transplant recipient with incidence of 4.5 to 33.8% and which causing the considerable mortality. A majority of cryptococcosis in solid organ transplant occurs late and it is due to reactivation of disease. So again, the treatment line is divided into three phases. That is induction phase, consolidation phase, and maintenance phase. Induction phase, we are starting the liposomal amphotericin B, that is 3 to 4 mg per kg daily, plus flucytosine, that is 25 mg per kg 4 times a day. Consolidation phase lasted for 8 weeks, in which we are starting fluconazole 400 to 800 mg daily, and maintenance phase lasted for 12 months, in which the main treatment is fluconazole 200 mg daily. Now the alternative treatment, if liposomal amphotericin B is not available, then we can start with amphotericin B lipid complex 5 mg per kg daily plus flucytosine 25 mg per kg 4 times a day. Or we can start with amphotericin B dextrine, that is 0.7 to 1 mg per kg daily plus flucytosine 25 mg per kg 4 times a day. If amphotericin B based therapies are not able to be used, then flucytosine 25 mg per kg 4 times a day plus fluconazole 800 to 1200 mg daily. Then the other treatments are voriconazole 200 mg daily, posaconazole 300 mg daily, isoconazole 200 mg daily, and itraconazole 200 mg twice a day. Now the recommendation for pulmonary cryptococcosis. So stratify the treatment disease severity and presence of pulmonary cryptococcosis. If it is severe, then same as for CNS disease and the doses that we have already discussed. But if it is mild, then fluconazole 400 mg daily for 6 to 12 months. Now, pulmonary cryptococcosis with CNS manifestation and other evidence of dissemination. As for it is same as CNS disease, and if the presence of cryptococcus in respiratory specimen is deemed as airway colonization after careful evaluation and no treatment is elected, then regular follow-up is recommended, especially in setting of future immunosuppression. The recommendation for a primary cutaneous cryptococcosis is attributed to direct inoculation without evidence of dissemination, and it is treated with fluconazole 400 mg daily for 3 to 6 months or until hit. For other non-CNS, non-pulmonary disseminated disease, the treatment is same as CNS. Cryptococcal eye disease should be managed in collaboration with ophthalmologist. Now let's talk about immune reconstitution inflammatory syndrome, that is IRIS. IRIS has been described in people with HIV, usually between 2 weeks and 3 months after commencement of the ARD. The patient develops exaggerated symptoms and signs or atypical inflammation and reminiscent of paradoxical recurrence. But cryptococcal IRIS can occur in the setting of immune recovery or withdrawal of immunosuppression. There is no diagnostic marker for iris and it is a diagnosis of exclusion. In cases of suspected iris, perform brain MRI lumbar puncture to measure opening pressure and get CSF for microbiological and biochemical analysis. So the treatment should include therapeutic lumbar puncture and symptomatic therapy such as analgesia, antiemetic, and antiepileptic. And we need to continue antifungal therapy. Also, the main treatment for this is high dose of prednisolone or prednisone, usually in the dose of 0.5 to 1 mg per kg or dexamethasone in the dose of 0.2 to 0.3 mg per kg daily, weaned over 4 to 6 weeks, and can be considered in those with persistent symptoms who are unresponsive to therapeutic lumbar puncture. Rarely, second steroid course with taper is needed. But we are not supposed to stop ART once it is started. And for the treatment of iris, so remember one thing, we always need to cure first opportunistic any opportunistic infection and then start antiretroviral treatment. And if you have already started and then if you are facing this iris, then start steroid. The steroid will have magical effect. And if you are and in case if you have already started ART, then please don't stop. Then our last discussion is on the cryptococcal gat. About 50 to 70% of cryptococcal gat infection occur in immunocompetent host compared with 2 to 30% in patients with HIV. Autoantibodies to granulocyte macrophage colony stimulating factor and idiopathic CD4 lymphopenia are risk factors. Notably, not all commercial lateral flow assays are able to detect cryptococcal gat disease. The antifungal agent used for treatment are same as for the cryptococcal neoformans, and 4 to 6 weeks induction therapy might be required in some cases of non-HIV associated meningitis with cryptococcal gat. Thank you guys.